PCOS, what every woman should know. Hi, I'm Dr. Dorothea Schliesinger, clinical endocrinologist, and today we will look at a condition that is both common but often misunderstood. It is the Polycystic Ovary Syndrome, or PCOS. Did you actually know that it is one of the most frequent endocrine disorders in women of reproductive age? In fact, it affects 5 to 10% of women worldwide, which is really a large number. And even though the term polycystic might sound very scary and alarming to you, it actually does not mean that your ovaries contain dangerous cysts. So how do we make the diagnosis of PCOS? It is actually made two of the following 3 criteria are present. So number 1 would be if you don't have an ovulation or your ovulation is irregular, which leads to irregular and infrequent menstrual periods. Number 2, if there is a clinical or biochemical evidence, meaning on your blood test or if visible, of androgen excess, meaning too much of male hormones, which can be expressed in acne, increased facial hair or body hair, or even thinning of your scalp hair. And number 3 is indeed ovaries that appear polycystic on ultrasound, meaning they contain many small follicles, small meaning they are between 2 and 9 millimeters. These follicles are actually immature eggs, which in PCOS, those immature eggs fail to mature and be released. And this is exactly why cycles become irregular and fertility is often reduced. But let me take a step back, tell you what PCOS actually is. It is a very complex disorder, and it is fundamentally a neuroendocrine metabolic disorder. And at its core lies a degree of insulin resistance present in the majority of affected women. So when the body becomes less sensitive to insulin, the pancreas compensates it by producing more of it. Then high insulin levels stimulate the ovarian Theta cells to produce more androgens, particularly testosterone. This excess of androgen and testosterone, to be precise, disrupts the normal communication between the hypothalamus, the pituitary, and the ovaries. And we call it the HPG axis, which then results in irregular ovulation. Thus, we have a cycle of insulin resistance, high insulin, high androgens, high testosterone, and no ovulation. But PCOS is not only limited to reproductive symptoms. It is indeed often associated with weight gain, impaired glucose tolerance, higher risk of type 2 diabetes, sleep apnea, fatty liver, and depression as well. And I guess understanding this helps us move from treating only the symptoms to actually addressing the underlying metabolic state. So at present, PCOS cannot actually be cured, but it can be very well managed. And one thing I always focus on is that the treatment must be actually individualized according to what my patient needs. Is the metabolic control the number 1 priority, or more of a symptom relief, or is the woman actually wanting to become pregnant? And the one thing I always advise my patient is to change their lifestyle. And the lifestyle interventions remain really the first line, such as balanced diet, regular physical activity, weight stabilization. It sounds all trivial and we all have heard of it, but it actually markedly improves the insulin sensitivity and hormonal profiles. Let me give you an example based on evidence. Recent data published in the Journal of Endocrine Society back in 2023, they analyzed several small clinical trials on women with PCOS who, interestingly, followed ketogenic diet for at least 6 weeks. And this meta-analysis demonstrated that those women had a mean weight reduction of about 11 kilograms, a decrease in free testosterone, an improved LH to FSH ratio, and a rise in sex hormone binding globulin, which we called SHBG. Let me tell you, these are really encouraging challenging metabolic and endocrine responses. Nevertheless, I am always evidence-based and fact-based, so the authors of that paper actually correctly emphasized that the studies were short-term and small, and the longer and controlled trials are actually required before general recommendations can be made. So what other treatments are possible? So for menstrual regulation, combined oral contraceptives remain the standard of treatment. When fertility is desired, ovulation induction with metformin or letrozole are effective and well studied. In addition, anti-androgens such as spironolactone may really help with acne or hirsutism. But with that drug, it is always important that there is some form of contraception. With structured management and regular follow-up, most women with PCOS lead entirely normal lives. I think that's something really important to stress because many are very afraid of this diagnosis. So in our patients, we monitor weight, the glucose, the lipid parameters, and adjust therapy as needed. So let me just go back and tell you the essential message. PCOS is a chronic but manageable endocrine condition. It's not a verdict. In endocrinology, precision matters more than fashion. If you suspect PCOS, seek actually a proper evaluation, including hormone testing and metabolic assessment, before you adopt any diet or supplement trend. Evidence, not speculation, is what truly restores hormonal balance. Thank you for watching.